So I'd now like to introduce Dr. Sue Yeoh, who is another of our core clinical research fellows, and her talk is entitled SGLT2 Inhibitors in Heart Failure and Diuretic Resistance.
Thank you. Let me share my screen.
Great.
Hi, so I'm Sue Yeoh, and yes, I'm one of the BHF core research fellows in the heart failure team here. And today I'll just give a brief overview of some of the highlights of the work done by the Glasgow heart failure team so far, in addition to the excellent work in cardio-oncology that Ninian and Stephen mentioned earlier in this session. And then I'll talk about DAPA-RESIST, which is this exciting new clinical trial that compares dapagliflozin with metolazone in heart failure patients with diuretic resistance. So just very briefly, the Glasgow heart failure team has an extensive portfolio of work, which includes understanding and studying the mechanisms underlying heart failure and heart failure therapy, as well as in epidemiology and using statistics and big data, and also in delivering landmark clinical trials such as Paradigm-HF, Paragon, and DAPA-HF, and also in developing heart failure guidelines and its implementation to improve the standards of heart failure care. And amongst the current BHF core research fellows at the moment in the heart failure team, our ongoing work covers a wide area of interest. So for example, Leanne's work, her project is to try and understand the role of inflammation and aging in heart failure patients. And Carly's work uses big data to try and understand heart failure populations. And they'll be presenting more on their work in session 2. While for my work, it's DAPA-RESIST, which is this randomized controlled clinical trial comparing dapagliflozin with metolazone in diuretic-resistant heart failure patients. So just a brief overview of what diuretic resistance is. It's broadly defined as inadequate diuresis despite high doses of loop diuretics, and there's no single accepted definition of diuretic resistance at the moment. Diuretic resistance is fairly prevalent, affecting 20 to 30% of patients with decompensated heart failure, and we know it's associated with poor clinical outcomes. We know the patients stay in hospital for longer, they're more likely to get readmitted to hospital, and have higher mortality rates. Sequential nephron inhibition involves adding a further diuretic agent with a different mode and site of renal action, and this is a crucial treatment strategy to overcome the resistance that can develop to a single diuretic agent. So current treatment guidelines for diuretic resistance involve adding a thiazide or thiazide-like diuretic, such as metolazone, in combination with a loop diuretic. However, this treatment strategy can have negative effects, such as worsening renal function and electrolyte disturbances. So looking at SGLT2 inhibitors, we know they're no longer just anti-diabetic agents. They've shown marked cardiovascular and renal benefits in large-scale HFrEF trials, regardless of diabetes status, and HFpEF trials are underway. And also, SGLT2 inhibitors have postulated osmotic diuretic and natriuretic properties, which is what we would like to further investigate in our trial. This just is a quick graphic showing the different sites of renal action of diuretic agents. So loop diuretics acting on the ascending loop of Henle, thiazides acting in the distal convoluted tubule, and SGLT2 inhibitors, as the name suggests, acts on the sodium glucose co-transporter in the proximal tubule. So we've designed DAPA-RESIST, which is a randomized multi-center open label study to assess the effect of dapagliflozin compared with metolazone on the diuresis and decongestion of heart failure patients with diuretic resistance. It is a multi-center study with 5 sites across the UK. So we have 2 in Glasgow, in the Queen Elizabeth and Glasgow Royal Infirmary, 1 in Paisley, 1 in Blackpool, and 1 in Leicester. This is a snapshot of our trial design. We're including patients with diuretic-resistant heart failure with any ejection fraction, so any left ventricular ejection fraction, whereby we aim to recruit 80 patients with HFrEF, which will be in our primary analysis, and up to 40 patients with HFpEF in our ancillary analysis. Patients should have a BNP of 100 or more, or an NT-proBNP of 400 or more, and an eGFR between 20 to 60. We're excluding patients with type 1 diabetes and patients who have had an SGLT2 inhibitor, thiazide or thiazide-like diuretic, in the past 48 hours. Eligible patients will be randomized 1-to-1 to dapagliflozin once daily or metolazone once daily for a 72-hour treatment period. And we'll be doing daily study assessments from baseline up to day 4, where we will be assessing urinary spot sodium, daily bloods, weights, fluid balance, urine output, congestion measured using lung ultrasound scans, patient symptoms, using patient-reported outcome measures, and safety questions. We'll also have a follow-up at hospital discharge and at 30, 60, and 90 days from randomization, which will be for worsening heart failure events and death. So this is our inclusion criteria. As I mentioned before, we are defining diuretic resistance as patients who are on high doses of intravenous loop diuretic. So an equivalent of 160 milligrams or more of IV furosemide in 24 hours. And despite that, having less than 1 kilogram weight loss or less than 1 liter negative fluid balance. And they should have ongoing clinical evidence of congestion, and they should be expected to be in hospital for more than 3 days. This is an exclusion criteria, as I mentioned before. And our main endpoint, so our primary endpoint, is the diuretic effect of the study therapy, assessed by mean change in weight from randomization to 48, 72, and 96 hours. And our secondary endpoints are change in congestion, which we're assessing using lung ultrasound, as well as loop diuretic efficiency. For exploratory endpoints, these are mainly changes in biomarkers, patient symptoms, and the rates of heart failure rehospitalizations or death. And our safety endpoints are mainly renal endpoints. So to summarize, the Glasgow Heart Failure Research Group has an extensive body of work which has transformed what we know and how we manage heart failure patients globally. In DAPA-RESIST, we aim to expand our understanding and the role of SGLT2 inhibitors to patients with diuretic-resistant heart failure. And last but not least, I would like to thank and acknowledge everyone involved in Team DAPA-RESIST. Thank you.